One, please start, ma'am. We are live.
Namaskar and good evening, everyone. I welcome you all for today's webinar on recent updates in HR positive, HER2 negative, advanced breast cancer. And with immense pleasure, I would like to invite Dr. Vamshi Krishna, who is Director, Medical Oncology and Hematology Institute of Oncology, AIG Hospitals, Hyderabad, to set the ball rolling and to take the floor. Over to you, sir.
Good evening, everyone, and thank you so much for that kind introduction. Today, we are here to discuss about HR positive breast cancer. We thought it would be interesting to actually go through the entire facets of treatment, which includes the recent advances for radiation, the advances in surgery, and then we'll go on to probably the main topic of the day, that would be the Cdk4 inhibitors and how we sequence these drugs in our clinical practice. We're already starting just a couple of minutes late, so without further ado, I would like to invite the first speaker for today, Dr. Ravi Shankar, who is a consultant radiation oncologist at the Omega Cancer Hospitals in Visakhapatnam. So he is going to be educating the rest of us non-radiation oncologists on probably the most interesting thing that has come about in breast cancer in the recent, that is the fast forward trial. Over to you, Dr. Ravi Shankar.
Thank you, Vamshi. Can I share the screen? Okay.
Yes, sir, you can.
Okay. Can you all see my slides? Okay.
Yes, sir.
Yeah, we can
It's
see the
visible.
slides.
Okay. Good evening, everybody. So this is going to be on adjuvant radiotherapy in breast cancer and more focus on what's called fast forward. So before we go on to the fast forward, how did we start our journey in managing the breast cancer, basically with adjuvant radiotherapy? So we all know that micrometastasis leads to eventual recurrences in breast cancer. So to counter this, or to control, or to eradicate the micrometastasis, we have wonderful approaches like systemic chemotherapy and radiotherapy. Okay. So before we plan an adjuvant radiotherapy for a patient who underwent surgery for CA breast, we take into consideration what's the age of the patient, certainly the performance status, tumor size, tumor histology, lymphatic invasion, proliferative rate, hormone receptor status, HER2 status. We don't go more into the gene expression signature because we have very limited data like Oncotype DX, how it really judges people who requires chemotherapy in a selective group of patients. Like we do also have with limited data on Oncotype DX guiding us whether this particular individual requires radiation or not, and definitely the preference by the patient. So coming to the early stage breast cancer, we know that in early stage breast cancer, breast conservative surgery is the main part of main approach that many of the surgeons they do, and then followed by you have radiation, because most of all the patients who undergo breast conservation surgery requires radiation. So coming to the radiation, basically when you want to plan the radiation, you need to position the patient properly. Immobilization, you have to use proper immobilization so that the patient can be set up very easily and comfortably every day. And then you need to do simulation followed by target volume delineation, and then plan the process. And then you have to plan what's the kind of a dose schedule and the fractionation schedule that you're going to follow, and then set up verification. And you'll also have to discuss with the patient about the sequel of radiation. So coming to the simulation, this is a very important step. We know that the most important area is the scar and the drain. So these two have to be marked. And what I generally do for all my patients is like the scar drain, I mark it, and then I also mark the entire breast contour so that unnecessarily I do not irradiate the chest wall. And that gives me more confidence when I'm doing the, contouring. And you can use some of the kind of system like motion management. You can use that. I'm going to discuss later on. So coming to the treatment planning system, like we have conventional planning, we have three-dimensional planning, we have intensity modulated radiation therapy. Fortunately, many of my colleagues are blessed with either 3D CRT or IMRT techniques. Not many people are doing conventional planning these days. Previously, when cobalt-60 was used, conventional planning was done. But today, with existing so many linear accelerators around, we are now using either 3D CRT or IMRT technique. So coming to the conformal radiotherapy, as I mentioned already, it's a setup, immobilization, and then you acquire an image and you need to delineate the target. Your target is going to be whole breast in the early disease of breast cancer. If you want to, like, if there is involvement of the lymph node, then you may have to include the axilla. If you are including the axilla, supraclavicular fossa has to be included. But coming to the internal memory chain, but not all the patients require IMN irradiation. Only select a group of patients where you have a high volume disease when you're tackling with, or if there is a tumor which is lying in the inner quadrant of the breast. And coming to the organ at risk, lungs are the most important thing. And second most is heart. Definitely, we don't delineate the left anterior descending artery regularly, but some of the centers, they do practice. Brachial plexus is not a problem at all for us because the tolerance for brachial plexus is pretty high. So this is how it looks like in an IMRT technique. This entire breast gets uniform homogeneous distribution. With wedges, if you're using the conventional technique, there may be an area of cold and a hot spot. So forward IMRT is nothing but field technique, which is being very much advocated by many people. This is how you can control your dose on the lungs and the heart. That is the inverse planning. It's called a. So undoubtedly, the radiation has really improved the patients with the post breast conservative surgery. And if you take any groups, like the absolute reduction in 10-year risk of any first recurrence is absolutely better with patients who have received RT. These are the lines. You can survival curves. You can see those who have undergone only BCS not doing well. Whereas the question here is boost field. Boost means you need to include the scar and the drain area properly into your boost field, and then you have to boost it with a higher dose, because we presume that the area which has been operated, that is the proper tumor bed, requires more radiation because that has got a high potential for recurrence. So you can boost it with electrons, which is generally done for many patients. So you have an linear accelerator, you must be having an electron. So electrons can be used. It's very easy and very low dose to the whole chest wall, and you get very good cosmetic result. Only issue is like when you're using a little bit of angle when you're delivering the electrons, you may have to be a little careful about your skin dose, because some of these patients can get skin reactions very badly. So your area of interest here would be like your lumpectomy cavity with a 2 centimeter margin on that. This is how it looks like. It's pretty easy. You can mark this is the area of interest that we are going to treat. And this can also be treated by a photon boost if you want to. So you can delineate, but this requires some amount of assistance from the surgeon, like placing a clip. You can see these are the clips that have been placed already by the surgeon, and you can also mark it on the scar, and both can be used for guiding your volume for boost. So here they have used many tangential fields. You can also use what is called a partial arc. So when you're using a partial arc, that arc comes from here to here, and then it will deliver dose to the interest of area. So you can also do an interstitial boost, but this is pretty, technically expertise is required for this. And sometimes the patients may not be willing to go for these kind of procedures, but this is also very equally good and very easily done. So boost versus no boost. So we have certain group of patients who may not require boost. That is, if the patient is more than 60 years or very, very low grade tumor, favorable biological profile, probably you can avoid boost. Why you have to avoid boost in these patients? Because if you avoid boost, like you can reduce the morbidity, like scarring and induration and local lymphedema, all those things can be reduced. You know, there'll be thickening of the chest wall in that area where you deliver more dose to the breast area. So cosmetic purpose, probably you can avoid boost in very selective group of patients. So other area of interest for today is how to reduce the cardiac toxicity. We know that these breast cancer patients require a lot of chemotherapy, ranging from anthracycline to the neratinib. All these drugs, lapatinib or trastuzumab, pertuzumab, all these drugs have got significant effect on the cardiac. So when you add on radiation with such cardiotoxic drugs, definitely the heart is not going to bear all these things. So you have to control your dose. In any case, you cannot control the cardiac toxicity by any of the drugs. But only thing is you can reduce toxicity by having a better technique by which you can reduce the dose to the heart. So how? This is a good piece of information from NEGM, where they mentioned that if you increase per gray to the heart, the incidence of cardiac related like coronary events or like coronary events or congestive heart failure is 7.4%. You'll be increasing. So that means every gray of radiation on the heart will increase that individual by another 7.4%. So there are various techniques by which you can reduce dose to the heart. Of all, the most most widely practiced, I would say, is deep inspiration breath hold. Today, most of the centers are practicing this. This is the picture what I'm talking about, deep inspiratory breath hold. So when you're doing this DABH, definitely you can go, your isodosis can go away from the heart. This is the free breathing. Certain amount of heart is included here that I'm going to show you again, by which you can avoid the dose to the heart. And you can also use respiratory gating, prone position, which is little cumbersome for the patient, but it's very good. If somebody has got a very large breast, probably prone position is the best way to reduce the heart dose. Or you can use a proton if patient can afford, or a PBA. So this is free breathing. You see, this amount of heart is included in your field of radiation. So definitely that contributes very high dose to the heart. This is breath hold. You can see very little amount of heart is included in your field of radiation. So you can see that this is the radiation field. I'll show you, this is the radiation field. And this is the heart, which is included in free breathing. And this is the heart, which is away from the PTV in breath hold. So breath hold, it freezes the organ and it separates the heart from the target volume, and it increases the total lung volume as well as reduces the dose to the heart. So what we practice in our hospital is SGRT, that is surface guided radiotherapy. This is how the patient is guided with, whether they're having a very good control on the breathe or not. You can see it on there is a bar here. So I'll show you in this video how I'll show you why. So this is the area of interest by treating, and these are the thresholds. This will be about 2 mm threshold. In case if the patient is breathing abnormally high, this is the bar which guides you whether the patient is breathing rhythmically or not. And if anything goes beyond this threshold, definitely this is going to be off. So it is 100% safety as far as patient is concerned, and patient doesn't require to keep any kind of a tube or anything like that in the mouth. So it's very easy and very happily or compliance wise, it's very 100% good for the patient. And as far as safety is concerned, it is 100% safety. So this is from the LNRT. We have got what is the system called 3D surface guided radiotherapy, first of its kind in this entire Asia, and we are proud to say that our center is a center of excellence for surface guided radiotherapy in India. Okay, so And then coming to the other area is accelerated partial breast irradiation. So why you need to do accelerated partial breast irradiation is the thought process for this is we need to irradiate only the area that is close to the tumor bed, that is about 2 centimeters tumor bed, which is got a high prevalence for recurrence. The rest of the breast tissue need not be treated at all. That is the concept. So how do you do this? So you can do either with interstitial brachytherapy or intracapillary brachytherapy like Marmocyte or routine 3D CRT or IMRT plan. So initially, the indications for partial breast irradiation from ASCO are very much limited, like confined to patients with 60 years old, negative margin, T1 lesions. Later on, the indications got expanded a little bit, but still, you have to be very careful. It should be either grade 1 or grade 2 tumor. It should not be more than 1.5 to 2 centimeters, though they mentioned 2.5, but I would say it's 1.5 is almost like a cutoff for all of us. So, and then with the negative margins. So all these things you have to keep it in your mind before you plan for a partial breast irradiation. Partial breast irradiation completes the treatment in just 5 fractions. We deliver about, these are various other techniques by which you can do a partial breast irradiation. This is intraoperative electron therapy, where the entire cavity is irradiated at the time of surgery itself, or you can do using 3D CRT or IMRT plan. So, as I mentioned in my talk initially, that is there anything by which you can avoid radiation, like how Oncotype DX risk score tells you that this patient does not require chemotherapy. Like that, we do have some trials like Lumina from Canada, IDEA from USA, and Precision, but the data is very much limited. But these trials, they looked at post-BCS operating like stage 1 disease, M0, high expression of ERPR and all those things. But still, I would say, if I have to omit the patient age has to be beyond 60 or 65 years, then happily, if the patient has got all the features like stage 1, node negative, ERPR positive, then I would probably discuss with the patient and then omit, because there the expected life is about 12 to 14 years. So, but in a case of a 50-year-old female, I cannot do the same thing because it's little probably a brave decision to take omitting radiation in BCS. Coming to locally advanced breast cancer. So, though like patients who have already undergone mastectomy and axillary dissection, is there any benefit? Definitely, there is a relative benefit in among all the groups like N0 or N1, like nodal status with N1 to N3. But there is also information that patients who have already undergone surgery and received chemotherapy, having the like omitting radiation. So here, if you see, patients who have not received radiation are doing worse than the patients who have undergone radiation, those who have received radiation. So that means that systemic therapy is not going to really replace this radiation at all, because systemic therapy is part of treatment, surgery is part of treatment, radiation is also part of treatment. We cannot omit radiation just because you cannot compensate by any other mode. So various dose fractions, because today that we're going to talk about is a fast forward. Before fast forward, we were using what is called 50 gray in 25 fractions, and then 40 gray. And then this fast forward came, which I'm going to tell you now. So coming to the fast forward, way back in 1986, there was a pilot study in UK. Actually, many of these individuals, like many of our friends who are working in UK, especially in Manchester, they keep on doing what is called hypofractionation. Before the concept came, when I was a student in CMC Vellore, I used to see the patients having treated with various different kinds of hypofractionation schedules at Manchester. Manchester is known for hypofractionation. So that's where the origin of these hypofractionation came. So they looked at 15, 25 fractions, 9 in 13 fractions, and 42 in 13 fractions. And then we started looking at what is called START A trial, where they compared 50 gray, 41, 39, and START B is comparison between 40 gray and 15 and 50 gray and 25. So that means by end of 2002, we were pretty confident that this 5 weeks of radiation can be replaced with 3 weeks of radiation. But coming into the practice, I think probably late 2012 or 14, people started practicing this hypofractionation schedules. And
Sir,
then
kindly conclude your talk.
So just
Okay.
requesting, sir, that 3-4 minutes only, if you could just
okay,
finish
I
it.
think I'm done with this. This is the last slide, I think.
Sure, sir. Thank you so much.
This is the fast forward. So fast forward, you deliver your entire dose of radiation that is either 26 or 27 gray in 5 fractions. This is what we usually practice. So you just push the entire dose of radiation in just 5 fractions. So this requires a little bit of more adjustment because you have to clip all these areas and then reduce your volume in such a way that you don't deposit dose onto this lung and heart. So this requires a little bit different contouring process and selecting the fields. So that's how you achieve your constraints. So this is the trial which we were talking about. To our surprise, this is something really good, because what we always think that when you're delivering over 5 fractions, we feel that the acute toxicity is going to be very bad. But on the other side, what we found is this is very well tolerated. Even in cosmetic wise, this is very good. So this is something which gives you an information that whether the patient receives 15 fractions in 40 gray or 26, all these things are almost similar as far as cumulative risk of any breast cancer related events are concerned. So 26 gray and 5 fractions has become a standard of care, especially during this COVID era, which has really taught us new lessons like hypofractionation. This is called ultra hypofractionation for prostate and breast, which are very common. So RT improves local control as well as overall survival. It's mandatory for post-BCS patients. Hypofractionation in breast cancer possible and can be practiced easily. Boost, maybe you can think it of. HIMAT is definitely preferred over 3D CRT and conventional techniques. Thank you very much. I'm sorry for, I think I have taken 5 more minutes.
Sorry to interrupt you for that, sir. Actually,
It's okay.
Yeah. So thank you very much, sir. Again, a very fascinating thing was, at least for some time ago, we used to think the radiation in breast is kind of done and dusted. The only thing is, like Dr. Ravishankar was saying, trying to look for subsets where you could probably give less or more or avoid radiation. That was all we were thinking. And suddenly fast forward came and really kind of opened our eyes to towards smaller radiation. Of course, the hypofractionation was already been there for the last 4-5 years. And now this trial is really establishing where you can reduce your radiation. So all in all, a very interesting trial, and I'm really happy to note people are following it up and using it as per the guidelines. So thank you, Dr. Ravishankar. That was a very excellent talk.
Thank you.
So
thank
next we will have Dr. Arvind Krishnamurthy, sir, who is a professor of surgical oncology at the Cancer Institute, Adyar. And again, I have he's talking on a very interesting topic. I think we have been discussing this issue for a long time. In a metastatic breast cancer, whether to operate the primary or not. That means, do you do a breast surgery or not? A lot of schools of thought, a lot of controversies and discussions keep happening on this. And I'm sure there's no one better than Dr. Arvind to give us the clarity on this in his speech. Sir, over to you.
Yeah, thank you, Vamsi. Good evening, everybody. Thank you, organizers as well. Yeah. Just wanted to let you give me permission to share, and I'm now sharing my screen. Yeah, right. Am I heard as well, and my screens are visible?
Yes, sir. We can hear you and see you.
Yes, sir. It's visible.
Great. Yeah. Thank you. As Vamsi said, this is a very controversial topic, and in the interest of time, I will try to fast forward this presentation as well with evidences. The traditional thinking was stage 4 breast cancer, or always has been a heterogeneous disease, even now. The traditional thinking was cure possibly is not possible. That was our earlier thinking. But now I think we know that a subset of patients of metastatic breast cancer can be brought into the realm of cure. But by and large, cure seems unlikely in a stage 4 breast cancer. Having said that, the median survivals of patients have drastically improved ever since the time of a couple of decades, now as much as median survivals may be in good responders, maybe as much as 3 years. Of course, the range is between a few months to many years. Of course, the reason for this hope is effective systemic therapies, endocrine and biological, and I'm sure that during the course of the webinar that happens in the next hour and a half, we'll be discussing more about this. This has been there specifically in the HR positive and and also the HER2 positive space. Also in the triple negative space, we do have some improvements. But by and large, if you see, the factors affecting the outcomes are a byproduct of the tumor and the treatment-related factors, important considerations being the age, performance status, comorbidities, extent, and biology of the tumors. And more importantly, the presence and availability of the effective systemic therapies. So by and large, if you see a stage 4 breast cancer, the evidence-based guidelines broadly says that systemic therapy is the mainstay of therapy. The issue for that we are trying to discuss today is of local management. Local management may be of the primary breast cancer, and that's what I'll be focusing on. There's also a lot of interesting data coming up in the oligometastatic sphere of metastasis-specific local treatment. I'll just briefly dwell on it for the interest of time and conclude my talk. When it comes to local treatment, it could be either a conservation or it could be a mastectomy. When it comes to metastasis-specific local treatment, it could be a metastatectomy, it could be radiation, it could be RFA, cryo, or any of the image-guided percutaneous procedures. Now is the more important question that we're trying to address: to operate the primary or not in a setting of a metastatic breast cancer. Of course, the answer I would say is yes and a no, and I would sort of qualify my statement in the following slides. Definitely, surgery is indicated for the primary in a metastatic breast cancer if the primary is symptomatic. Of course, this is an important consideration. If there is pain, bleeding, ulceration, infection, or any other aspect associated with poor wound healing, the act of surgery is justified. And this is not just in this solid tumor, but possibly in many other solid tumors as well. But the issue is whether in the presence of an asymptomatic primary tumor, whether you want to remove it in some form, either as a conservation or the mastectomy. I must say that it's not yet completely considered standard of care, considering that there is not much evidence to say that it really improves the overall survival, and coming to those evidences in some form in some time. But I must say that there could be deviations in this approach, and largely it must be on a case-by-case basis in a multidisciplinary setting. For example, I give you a specific case scenario of one of our patients who we had managed, a 47-year-old lady post-hysterectomy, carcinoma right breast. She was T4P N3CM1, bilateral supraclavicular, and contralateral axillary node was positive. Of course, at that time, we felt that the intention of treatment was palliative. We gave her 6 cycles of Taxol trastuzumab, a PET-CT done for an assessment, showed a vague residue in the breast and a complete metabolic response otherwise. So we were in a dilemma whether to add locoregional treatment to the primary, or we should further add metastasis-directed treatment as well. So to cut the story short, we decided in the interest of the biology of the disease, in the interest of the presentation, that we would continue systemic therapy only for this patient. So we continued this patient on single agent trastuzumab. After 3 months, a PET showed progression only at the breast tumor site. Rest continued to be a metabolic CR. In view of local progression, again in this patient, surgery for the local site was justified. Of course, this is not purely in the realm of asymptomatic patient, but because there was a local progression, there was symptom associated with it, we were justified in going ahead with a palliative mastectomy. Surgery is also justified, as I said in this case, when the dramatic response to the systemic treatment has been there, but subsequently the primary has been progressing, as in this case. Or it could also be justified when the primary breast mass is amenable for resection, it's possibly close to ulcerating. So in this case also, in this scenario also, maybe surgery might be justified. What are the evidences? Of course, you have a lot of retrospective evidence. It's very difficult for me to collate at least 17 to 20 trials of or studies, retrospective studies are set. And by and large, the vast majority of the retrospective evidence actually support local treatment in stage 4 breast cancer, but I must say that the quality of the data has been retrospective. There has been instances of selection bias, and most of these studies have concluded that they required randomized controlled evidences. We have 4 randomized control evidences. In this order, I would go the trial from Dr. Badwe et al., the TMH trial, I would name it, the Austrian trial, the ECOG E2108, and the Turkish trial. Very quickly, I would sort of run into each of these trials. The TMH study, 350 patients, resectable hormone positive breast cancers after anthracycline-based therapy. If there was a CR or a PR, they were randomly assigned to surgery versus local regional treatment, published in the Lancet Oncology about 7 years back. Median follow-up 23 years, no difference in the overall survival. Although local regional treatment was associated with improved local regional PFS. But then again, there were slightly questions asked about the availability of systemic therapy. For example, the trial mandated use of appropriate endocrine therapy and HER2-directed therapy, but the criticism was that the majority of the patients did not receive. But that's how the real-world data is. So we had this wonderful trial from India that said that there was no statistical significance in the overall survival when surgery was added in the setting of a metastatic breast cancer. So this observation was also seen in the Austrian trial, 90 patients, stage 4 breast cancer. Of course, this trial was closed prematurely because of poor accrual. Median follow-up of around 37 months, no difference in the overall survival. Surgery also did not confer benefit for the local regional metastasis, also for time to local regional metastasis or the quality of life as well. Very hot off the press, the ECOG Actrin 2108 trial, 256 patients, published earlier in this year, presented last year, but published earlier this year in the JCO. 4 to 8 months of therapy in stage 4 breast cancers de novo, randomly assigned again to local treatment, no local treatment. A median overall survival of 53 months, no difference at 3 years between both the groups. So there was no difference in the overall survival rates in this trial as well. Of course, there was a 3-year local regional progression was higher in the patients receiving systemic therapy only. The Turkish trial is the outlier trial. In fact, it was one of the first trials, but I was presenting it last because there were 3 trials that were negative. The Turkish trial was the only trial that seemed to be positive. 274 patients, de novo metastatic breast cancer. Unlike the couple of the other important trials in this, the patients were actually offered upfront surgery in the presence of systemic disease, either a mastectomy or a conservation, followed by systemic therapy versus systemic therapy alone. Although there was no difference in the 3-year OS, the 5-year OS actually favored the surgical arm, 42% versus otherwise. But however, there were a lot of criticisms of the trials that the arms were not balanced in both the groups. For example, patients randomized to local regional therapy had lower rates of triple negative, higher rates of hormone positive. We know that possibly the better prognostic group was in the group that actually received the local regional therapy, and also solitary bone metastasis. We know that most of these patients are now considered as oligometastatic and are actually not considered in the spectrum of polymetastatic diseases. So again, the post hoc analysis of the Turkish trial, we found, or at least the authors found, that hormone receptor positive HER2 negative disease, age less than 55 years, or a solitary bone metastasis. And these were the patients that actually benefited from the upfront surgery group. But as I said, that this is a post hoc analysis, and of course this trial had various other criticisms as well. There is a future trial of JCOG 1017, a similar trial to the ECOG 2108 trial, and we are awaiting the results. Having said that, there is a spectrum of disease called the oligometastatic that's more controversial. I don't really want to throw more light on this in the interest of time. Most of us are aware about this concept, not just in breast cancers, but also in many other cancers like lung, prostate, colorectal, etc. And it is known to be some sort of an intermediate state. Of course, we need to understand many terminologies to understand oligometastasis. It could be de novo, oligorecurrence, induced oligometastatic, or oligoprogression. Of course, you do have level 1 evidence in oligometastatic disease, the Saber-Comet phase 2 randomized controlled trial, which actually randomized patients with 1 to 5 metastatic patients, 99 patients from 10 centers, 18 of them were breast cancer primaries with a median follow-up of 51 months. It found that the 5-year overall survival was best in the arm that was offered treatment both for the primary as well as for the metastasis as well. But again, there were a lot of other criticisms of the trial, considering the fact that it was 99 patients over 10 centers. Breast cancer patients were slightly more, and a lot of prostate was also more. So it had a number of patients with sort of, the biology which was more favorable, and it was a mixture of many cancers rather than one cancer as well. So there are a lot of ongoing future randomized controlled trials that are trying to address this. So I must say, to conclude, I'll just give you a glimpse of whatever evidences are there, retrospective evidences that are largely favoring a local regional treatment for the primary. However, the randomized controlled trials, they were mixed, 4 randomized controlled trials, 3 of them against surgery, 1 of them the Turkish trial for surgery. Of course, each of these trials have their pluses or minuses. I must definitely say that local regional treatment for the primary and possibly metastasis specific local treatment is in the oligometastatic disease may palliate existing symptoms. That is, if the patient is symptomatic for the primary or symptomatic to the oligometastatic site, you may be justified in offering local treatment in the form of surgery or otherwise to some of these patients, although the impact on overall survival is not clear. But by and large, if the patient is asymptomatic for the primary or the local regional site, the primary goal should be systemic therapy and local treatment should be kept at reserve. However, there could be certain exceptions that can be made in rare circumstances, as in the case scenario that I described, and each of this can be taken on a case-by-case basis in a multidisciplinary form. Thank you for the opportunity and looking forward for the rest of the seminar.
So thank you so much, Dr. Arvind. This was, as usual, excellent lecture. And really, you have highlighted all the various trials. And, we do keep having this discussion in every tumor board. I think this is the case where we have the maximum discussion. What do you do in the oligometastatic? It is sometimes our hope and, wish that all oligometastatic would be cured and let's go aggressive. It would be nice if the data comes to support this, though right now it is not there. So again, thank you so much, sir. I think if anyone has any questions, you can just put it in the chat box as well. We could address them at the end or during the panel discussion. So the next talk is going to be by Dr. Charu Bahal from Medgenome. She's the chief scientist of Medgenome from Bangalore. And she would be talking about, again, something which is coming up in a big way, the Pic3 mutation. Again, as medical oncologists, the more we test, the more we find this mutation. And not just in breast, we are finding Pic3 now sorts of unusual cancers. How much that is really significant, and at least in the context of breast, which are the Pic3 mutations that are significant and how do we detect these? Dr. Charu would be talking on this topic. So over to you, Dr. Charu.
Thank you so much. I'll just share my screen now. So yes, please let me know if it is visible. Yeah, I hope the screen is visible.
Yes, yeah, the screen is visible now.
Okay. So very good.
You can just make it a big screen. If you can just make it a full screen, that would be.
I have done that. Yes.
Yes, sir. It's visible.
Okay.
It's visible.
Okay. Thank you so much. So as Dr. Vamsi Krishna introduced, I am going to talk majorly about picking the correct mutation. So in a way, talking about Pic3 Cm mutations. So I'm very grateful for the opportunity, and I'll try to keep it very short and crisp, and so that we can have a discussion after. So majorly, I'll be talking about the biomarkers, genetic alterations in breast cancer, Pic3 Cm mutations, ESR1 mutations, and certain laboratory specifications which are important around this. So firstly, breast cancer, as we all know, it accounts for almost 14% of cancers in Indian women, and it is reported that every 4 minutes an Indian woman is diagnosed with breast cancer. It is the most common type of cancer. According to Globocan 2020 data, there were 17,836 361 new registered cases, and 90,408 reported deaths. So this is the recent data around breast cancer. Now, for the biomarkers, as you can see in NCCN guidelines, there are relatively, ERPR testing, HER2 testing. So in here, ERPR testing has to be done for almost all the breast cancer patients. That is kind of an initial diagnosis process. And then HER2 testing is also to be performed on all new and primary or newly metastatic breast cancers in a ASCO or CAP accredited HER2 testing guideline method. Then if you look at the biomarkers which are listed for invasive breast cancer, that is your advanced breast cancer cases, we have BRCA1, BRCA2, germline sequencing for, olaparib in any kind of breast cancer subtype, be it HER2 positive, HER2 negative, or hormonal positive, hormonal negative. Specifically for hormonal positive and HER2 negative breast cancer tumors, Pic3 Cm mutations are coming up as an important mutation testing, because there is an FDA approved therapy which can be given to the patient in terms of alpelisib plus fulvestrant, and definitely it is in terms of second line or subsequent line of therapy. Then you have in case of triple negative breast cancer, PD-L1 expression, then NTRK fusions in any kind of breast cancer cases. Other than that, MSI and TMB for available as immunotherapy agents. So these biomarkers are to be tested before deciding on the benefit of the patient per se to immunotherapy as a treatment. After that, this is just a consolidated list of all the biomarkers that pertain. Certainly, you come across in case of breast cancer patients, which are to be routinely done in terms of getting the clear understanding of the treatment. You have ERPR, HER2, definitely protein expression and amplification. Then Pic3 Cm mutations, which are majorly activating mutations. That is where the gain of function of Pic3 Cm protein happens, and incidence in Indian population is almost up to 28% specifically. Coming to ASCO guidelines, which are just very recent, they have recommended Pic3ca testing using either tissue or ctDNA by NGS. That's a very important recommendation, and in terms of tissue availability, it definitely becomes sometimes a major roadblock for when we are looking forward to test for the patient. So certainly ctDNA, that is cell-free DNA testing for Pic3 Cm mutations, is now recommended by NCCN and ASCO both. Then you have BRCA1, BRCA2 germline testing, PD-L1 by IHC, MSI, or DMMR, and TMB and NTRK fusion. So these are the recommended ones, which are definitely as an upfront testing should be offered to the patient. Coming to germline and somatic mutations, definitely in terms of detecting the germline mutations, because they are present in all the cells of the body, they are inherited, so they could just be detected with a simple blood draw. However, in case of somatic mutations, they have to be captured through testing the tumor tissue or even the cell-free DNA these days. So as we have already discussed, there are major genomic alterations which are having high penetrance, that includes BRCA1, BRCA2, TP53, PALB2, PTEN. These are all germline mutations that contribute to occurrence of breast cancer. And the somatic mutations, that is the mutations that take place specifically in the breast tissue, they include Pic3ca and ERBB2, which are majorly causing the tumor to be formed in the breast. So BRCA1, BRCA2 testing has been already, I think it's quite evident, so I will not take much of a time on highlighting that. I would just like to highlight our experience as a as a big big center, testing almost more than 20,000 patients now. And we have got one information, that is that the MLPA percentage in breast cancer cases, that is BRCA1 BRCA2 large deletion duplications, are not found in more than 1 to 2% patients. So as per Indian data, more of the patients are having definitely point mutation itself in the BRCA1 and BRCA2 genes. And if you look at the reason, should a family history be a contributing factor, as per our database, even patients without family history showed almost equal percentage or frequency of BRCA1 BRCA2 variants in in families where there was no cases of familial cancers before. So definitely somatic testing can capture both germline and somatic variants. So tumor testing is more prevalent these days because of the only reason. Now coming to the important topic of Pic3 mutations. So majorly the Pic3 molecule is present in kind of a downstream in the cell signaling pathway, where it has RAS binding sites and kinase sites and helical binding sites. The gain of function mutations majorly takes place in the exon 7, exon 9, and exon 20 region, and these are the commonly found mutations in those particular exons. Now detecting why we have to definitely look for Pic3 mutations is because in case of early breast cancer, it is related to better disease-free survival and better overall survival. And in case of HER2 positive breast cancer cases, it is associated with lower pathological complete response rates. And in case of HER2 negative hormone positive, it is related to poor outcome and resistance to chemotherapy. That is majorly because it constitutively activates the mTOR pathway, which is downstream in the cell signaling. And the most important point is alpelisib and fulvestrant, which is indicated to treat the postmenopausal woman with hormone positive HER2 negative Pic3 mutated tumors, which are metastatic breast cancer and have been showing progression on endocrine based regimen. Also, another important point is patients who are having double Pic3 mutations. They are almost 4% of all the breast cancer cases, and they showed an overall survival or odds ratio of to Pic3 inhibitor was double higher in double mutant as compared to single mutant Pic3. So the double mutant Pic3 patients will have a better ORR, that is overall survival, as compared to patients having single one. So this is that same data which I just discussed. Now, when we have to test the Pic3 mutation testing, once the initial workup for IHC is done, chemotherapy and endocrine therapy is given as per the initial IHC workup, whether it's a hormone positive, hormone negative patient. After that, if there is a progression and resistance, and also, as per the, if it is a stage 4 patient, then Pic3 testing should be done to avert if the patient will respond to chemotherapy or not. And as per guidelines, if you see, in Pic3 testing is now recommended as an initial workup in metastatic breast cancer patient. And if the patient has stage 4 disease, if the tumor is hormone positive and HER2 negative, and if there is a consideration that the clinician wants to look for a targeted therapy. Definitely there the patient has to start with endocrine therapy before, and must be showing progression on that. And then Pic3 testing can help in better prognostication and treatment planning. So how to test Pic3? Yeah.
Ma'am, we need to move forward.
Okay. particularly the main test which I wanted to discuss was RT-PCR Pic3ca testing. So RT-PCR Pic3ca testing can be done both on liquid biopsy and tissue samples, and this is available with MedGenome. NGS has better results in terms of detecting all known and unknown variants. However, RT-PCR is more cost effective and has sensitivity rate, and also gives you faster results as compared to NGS. So I think as there is a constraint of time, so I will just wind it up by coming to the key takeaways. So the key takeaways is that NGS is the best choice of method for BRCA1, BRCA2 testing, and upfront testing for Pic3ca in hormone positive, HER2 negative breast cancer patients is important for better prognostication and treatment planning. Both tissue testing and liquid biopsy testing can be used. If liquid biopsy is negative, then tissue testing can be recommended to avoid false negative results. And comprehensive tumor profiling in case of metastatic breast cancer can identify all the relevant alterations like Pic3ca, ESR1, CDK4, CDK6, and HER2 genes at a single shot. So it can be a one-stop solution. So NGS block preparation is a very important, crucial step for a successful NGS assay. So I think that will be all from my side. So if there are any questions, I can take those in the chat. Thank you so much.
Thank you, Dr. Charu. I think again, in the interest of time, I don't see any questions as of now, but if case comes, we will get back to you. For me, the most important two takeaways which you said, one is if the liquid biopsy is negative, please go for a solid. You do have false negatives. I think that's an important takeaway for all clinicians. And secondly, the double mutant that you spoke about, that is important, which to be honest, I don't really look at. Now that you have told me, I think we are going to start looking at these two. So
Sure,
thank you so much. Thank you so much, Dr. Charu.
Thank you so much.
And
thank you.
For the next talk, I would like to invite Dr. Satya Dattatray, who is a mentor for all the medical oncologists in Hyderabad. And he is a senior medical oncologist and chief of medical oncology at the Renova Soumya Hospital in Hyderabad. So he will be talking about a very weighty topic. His topic is quite long, discussing ribocyclip real-world evidence, as well as randomized control trials and bridging that divide in over 8,000 patients. So over to you, Dr. Satya.
Thank you. Thank you so much, Vamsi. And a very good evening to all of you. So let's try to straight away go to talk about getting real with ribocyclip. Now, we all know that we have randomized control trials, but we also talk about a real world evidence. Can I have my slides, please? I think as we all know, when we do consider options in advanced breast cancer, one of the most important treatment goals is that intervention improving the overall survival or not. More often than not, OS is not the primary endpoint. It's a very important secondary endpoint. And if that intervention can improve the OS, then I think that becomes a gold standard endpoint for efficacy measures in various oncology trials, especially metastatic breast cancer or advanced breast cancer trials. Can we have the next slide? Are my slides visible?
Some issues, now they are visible, sir.
Yes. So ribocyclip, as we all know, across various phase 3 trials has shown to improve the overall survival significantly when added to either an AI, the next please, or fulvestrant. MONALEESA 2, MONALEESA 3 and 7, all of them showed a significant OS advantage. Across all the 3 trials, the primary endpoint was PFS, but then an important secondary endpoint was OS and also the safety and the tolerability. Next slide. If you look at all these 3 trials, the delta, the difference has been in the tune of 11 to 16 months, which means that adding ribocyclip increased the median to approximately 1 year. And the median OS is around 5 years now when given as first line across various endocrine partners, or be it premenopausal or postmenopausal. So with that brief overview of the Mona Lisa trials, let's look at some real world evidence. Next slide. And let's try to say that it's consistent with the previous phase 3 studies we discussed. Next slide. And these two trials are, one is called as the complement and the second is a Ribana. The complement was a phase 3b international study and the Ribana is a German study. In total, the number of patient population across these real world studies comes to close to 6,000 patients. Next slide. In the complement study, the primary endpoint was safety and tolerability, looking at ribocyclip and letrozole in close to 3,000 patients. Next slide. So let's look at this largest real-world study across the Cdk46 inhibitors. And as we know, in real-world practice, you will have diverse subgroups. For instance, next slide, there were patients who had CNS metastasis. Some of them where the ECOG PS was around 2, and some who had received prior chemotherapy advanced dose, and then afterwards went on to get the combination of ribocyclip with an endocrine partner. And there were some patients who had visceral mets and ECOG PS of 2, some who had visceral mets and got chemotherapy. So a diverse patient population. Next slide. The primary endpoint of safety profile, which was predictable, manageable, and similar to the phase 3 randomized control trial. As we all know, as time goes by with prolonged exposure, the events reduce. Next slide. The TTP was 27.1 months and the median PFS was 26.7 months. So in excess of 24 months, which is what we have seen with the randomized phase 3 trials also. Next slide. If you look at those patients with measurable disease, overall response rate of around 45%, clinical benefit rate of 70%. Now, in this trial, next slide, you had 51 patients who had CNS metastasis also. If you look at the randomized phase 3 trials, 2 and 3 patients having CNS mets were not there. In Mona Lisa 3, you had 8 patients who had stable CNS metastasis. In the Monarch trials also, patients having CNS mets are excluded. But you did have a phase 2 randomized, non-randomized study of abemaciclib, where you found a clinical benefit rate of around 25%. The overall response rate, the abema was only 6%. Now, complement is a phase 3b real-world study where 51 patients had CNS metastasis. Next slide. Now, be it patients who had CNS metastasis or who received prior chemotherapy or an ECOG PS of 2 or visceral metastasis plus prior chemo or ECOG PS of 2 across all subgroups of clinical interest, the efficacy has been consistent with this molecule. So adding ribocyclip to endocrine therapy across various subgroups in real world evidence was able to show consistent efficacy. Next slide. Now, what about the well-being scores, functional and emotional? At this point of time, the patient reported outcomes in the real world evidence of complement study shows that the quality of life was maintained while on treatment. Next slide. Let's now look at the German Ribana clinical evidence. Next slide. Now, here you had multiple options which were given to patients, which were taken by patients, of which close to 2,000 patients went on to get ribocyclip and an AI or fulvestrant. Some close to 200 patients went on to get only endocrine monotherapy, and 145 patients got chemotherapy as the first line treatment. Next slide. Now, if you look at the median PFS with chemotherapy, it's around 15 months. With endocrine therapy alone, around 26 months. By adding ribocyclip to a fulvestrant, it was around 31.7 months. So clearly, the balance seems to be tilting towards the combination of ribocyclip plus an endocrine therapy. Safety and treatment. Next slide. The safety profile was similar to what was observed in the Mona Lisa studies. The most frequent treatment emergent adverse events were neutropenia, nausea, fatigue, and leukopenia. Next slide. Now, the outcomes what we see in phase 3 in these two phase 3 trials, which are real world evidence, is also what we saw in the previous 3 phase 3 trials. The median PFS seems to be across all these 5 studies in excess of 24 months. And discontinuations happening because of adverse events are around 10% only. So be it the safety, the AE profile, the tolerance, or the efficacy, the real world evidence seems to mirror the randomized phase 3 control trials. Next slide. Various guidelines, NCCN and ESMO guidelines also therefore recommend ribociclib plus endocrine therapy in the first line setting. Next slide. If you look at something called as the Mcbs score by the ESMO, then the score is 4 or 5 with ribociclib. So that's the advantage of adding a Cdk46 inhibitor like ribociclib, because you are able to get a Mcbs score of 4 or 5. We also are realizing that the 3 Cdk46 inhibitors are different. I would not say grossly, but then there seems to be some difference across between palbociclib, ribociclib, and abemaciclib to bring out some differences. Next slide. Next slide, please. For instance, adverse events with regard to hematology happens more often with palbociclib and less often with ribociclib or abemaciclib. That's because the number of off-target kinases inhibition is happening by ribociclib is much less when compared to palbociclib or abemaciclib. Next slide. Ribociclib also seems to have more selectivity for CDK4 than CDK6, and the same is also true for abemaciclib. Next slide. But with regard to palbociclib, CDK4 and CDK6 inhibition seems to be almost equal. So to summarize, the real world evidence trials with the phase 3 trials, the outcomes from randomized control trials can be replicated in real world experience. Guidelines recommend the early use of CDK46 inhibitors, and ribociclib has shown one of the longest median OS of close to 64 months from the Mona Lisa 2 study. When you combine that with letrozole, it significantly improves OS across various lines of therapy, be it pre or postmenopausal, and whatever with endocrine partner. Across the phase 3 studies, the magnitude of clinical benefit scale score is 4 or 5, which tells us about the quality of life being maintained with this molecule. Looking at almost close to 6,000 real-world cases, it has shown similar efficacy and safety. So with that, I would like to conclude my talk by just telling that the real-world evidence seems to mirror what the phase 3 randomized controlled trials of ribociclib combinations have shown. Thank you so much, Vamsi Krishna and one and all.
Thank you, Dr. Satya. This was, as usual, a great talk. And it's heartening to know that at least we have some real world evidence that seems to back up the data of what's happening in the clinical trials. I think that's the bottom line for every one of us, that at least in the real world, the drug doesn't seem to behave very differently. And it just strengthens our confidence in the drugs, if I can say. So next we'll go ahead with the panel discussion. And in the panel discussion, we have Dr. Rachna, consultant medical oncologist and assistant professor at medical oncology at Nizams. Dr. Rachna, are you there?
Yes, sir, I'm there.
Next, we have Dr. Bala Stalin Chaudhary, again an assistant professor at the Department of Medical Oncology at the NIMS, Hyderabad. Dr. Bala,
yes, sir,
I'm
there. I'm there.
Okay. Dr.
Yes.
Rekha Bansal, consultant medical oncologist in Apollo Hospital.
Yes, sir.
Dr. Rekha, you're there? Okay.
Yes, I'm here, sir.
Dr. Saju SV, consultant in the Department of Medical Oncology, Hemato-oncology, Pediatric Oncology in BMT at the Meenakshi Mission Hospital in Tamil Nadu. Dr. Saju, are you there?
Yes, sir, I'm here.
Yeah, hi. Next, Dr. Biswajit is there. He said he might not be able to join. He had some urgent thing coming up. Yeah,
No,
I think
sir, he is not joined.
He is not joined. That's fine. Dr. Vinayak Maka is a HOD and Senior Consultant, Medical Oncologist and BMT Physician at the MS Ramaya Hospital at Bangalore. Dr. Vinayak, are you there?
Yes, Vamshi, I'm there.
Yeah, great. So what I'll do is we are running a little late. I will not take too much time in the next 20 minutes or so. We'll just talk a little bit about sequencing agents for HR positive in clinical practice. Now, I'm not going to go into the depths of each trial because frankly, we have been doing that for a long time. And this is possibly, I don't know which number of, moderation or discussion we have been having on the CDK4 inhibitors since the last few years. So next slide, please. I'll just start off with a simple case, a 74-year-old lady who basically came with only back pain. Evaluated by an orthopedician, only analgesics were given, then MRI spine was done, which showed multiple lesions in the spine. So after that patient was referred to us, where on questioning, she actually admitted to having a lump in the breast, which was around 4 into 3 centimeter in size. Biopsy was done, came as an infiltrating ductal carcinoma, ER/PR positive, HER2/neu negative. Next slide, please. So this is the image. Now, as you can see, the breast lesion is quite large, multiple few mediastinal nodes, multiple bone lesions. You know, the entire spine is almost studded with lesions, and a couple of liver lesions as well. So next slide. So for me, the most important thing to begin with, Dr. Rachna, do you look at this as a visceral crisis, as a visceral disease? Are those terms that are still in use? Are we looking at a visceral disease or a visceral crisis?
Yes, sir. Visceral crisis, yes, we need to look for every ER/PR positive metastatic breast cancer. And that, as we all know, the definitions, the deranged LFTs or presence of lymphangitis carcinomatosis, patient is symptomatic for lung metastasis, those we have to consider because we need to give them chemotherapy. And coming to visceral disease, if we are speaking about the CDK4/6 inhibitors, yes, there is some slight difference being shown between palbociclib and ribocyclib and abemaciclib, with palbase being slightly effective in the bone-only disease. Yeah. Okay.
We'll come to those differences. So, no, the reason why I'm asking Dr. Stalin, if you can take this question, saying, is this concept of a visceral crisis, has it evolved over the past few years? I mean, are we 5 years back or 10 years back, anything with disease not in the bone would qualify automatically for chemotherapy? Are we still looking at that scenario or has it changed? So I just wanted opinion of the house on that. Dr. Stalin, and then maybe Dr. Rachna can take it again.
Yeah, it has changed a bit with the advent of the CDK46 inhibitors. So possibly previously all the disease which is there in the visceral disease, patients we tend to treat more with chemotherapy, and bone only disease most probably we treated with endocrine therapy. So with the advent of CDK46 inhibitor, so possibly we'll be using chemotherapy only for the patients who are breathless or who have a deranged LFT. So we have significant organ dysfunction rather than mere presence of metastasis in the visceral organs.
So, Dr. Rachna, considering this definition of altered LFT, again, are we now stretching the definition a bit that, looking at reasonably good PS, just having altered LFT, would you still go for a chemo? Or is it something to do more with the performance status? Or how do you decide what is a visceral crisis?
It's more depends on the performance status and the disease burden, sir. Not just the LFT, because if we consider a mild derangement of more than 1.5 times the upper limit of normal, we may not directly go ahead with the chemotherapy. And we also were a part of the Right Choice trial, which was looking at the patients with visceral crisis on CDK4/6 inhibitors. We are awaiting the results. So maybe it will better help us.
Wow, that will be really useful. Dr. Rekha, in your practice now, in how many actually cases of visceral crisis are we seeing? Again, considering all the disease that we see, what would be the percentage where you would say this is a visceral crisis?
Less than 5%, I would say, sir. I mean,
less than 5%.
Most of the,
Yeah. Dr. Saju, do you agree with this? I mean, it's less than 5%. Is it as much as it used to be?
In our clinical practice, it is a little bit on the higher side, probably around 10 to 15%.
10 to 15%. So again, it's interesting that, even though you're saying it in your clinical practice and still it's only 10 to 15, that's something which is, I think, heartening. The patients are coming earlier, but at least personally, the confidence we have in using CDK4/6 and endocrine therapy for a visceral disease is, I think, quite robust now. We don't automatically jump the gun. In fact, I try to look actively for a place where I will avoid chemotherapy And I don't know where we would have last used. Dr. Vinayak, last 100 patients, how many have you actually used chemotherapy in metastatic breast cancer? HR positive, of course.
Not defined by a visual crisis, but definitely I used 30% of patients with
30%
chemotherapy.
Okay.
Yeah, but one thing is there, which I think this patient is differing, is the de novo it is there. For de novo, I have not used much of patients with chemotherapy.
I'm sorry, Dr. Vinayak, I think I lost you.
Yeah, de novo patients, like for the patient present, like this patient, she is of upfront metastatic disease. I would try some hormone therapy before I go for.
Okay, but you would not go for chemo at least. I think that's the point which I'm trying to get. Will you use chemo?
Yeah, I would not go. I'm not gone in any chemotherapy for any patients who are upfront metastatic disease, hormone positive. I have not seen any visual crisis of late, but definitely.
Perfect. I think that's the point we are getting. A group of medical oncologists, all of whom are saying, let's not give chemo and let's try something else. That's the real paradigm change that has happened in the past 5 years. Next slide, please. So again, now this is what we were discussing, and I think this has been answered by everybody. You would go with an AI with a CDK4 inhibitor, I guess. Regarding the AI alone, fulvestrant alone, I don't want to get too much into detail, but just Dr. Rachna, just if you can say, is there any patient, logistics and affordability aside, where you're comfortable with using only an AI or only a fulvestrant, or would you be comfortable using CDK46 everywhere in combination?
I would be comfortable using CDK46 combination, sir.
Perfect. So, Dr. Stalin, any patient where you would like to use, again, I'm just stretching the boundaries of our clinical practice and asking you, this is not a, hard and fast thing.
Sir, majority of the times, in fact, 100% of the times, my choice is AA plus CDK46, and I will reserve the fulvestrant in the second line.
I kind of agree with you. I think the only off cases are those rare incidents where you have a patient relapsing with a single bone met, which you would treat as an oligometastatic and things like that. But otherwise, any patient with a metastatic, frankly, metastatic breast cancer, I think all of us are now comfortable with using a CDK46 plus a AI in the first line. So next slide, please. So one thing is, this is regarding the decision of therapy of using CDK46. Would anything like the age or the performance status or the comorbids, would they play any role? Dr. Rekha, would that matter to you before you give any chemotherapy?
No, sir, certainly. So, I mean, none of them matter because I think CDK46 inhibitors are pretty much tolerable. I guess we are not talking about which CDK46 inhibitor, but
that's next. Yeah.
So, age no bar, PS no bar. I think we do have something for everyone. So, yeah.
Fantastic. So, what's the oldest patient you have given CDK46?
80-year-old, sir.
80. Okay.
Unfortunately, I lost her within 2 months due to other reasons. But yeah.
That's sad. But yeah, 80 years. Okay. Dr. Stalin, your record?
Possibly 80 years. 80, sir.
80. Okay. So, Dr. Saju?
65, I think.
65. Okay. You're still back in the race. You need to get the elderly people, I think, in more. Dr. Vinayak?
Yeah, 82.
82. So I think I'm the winner. I have an 84-year-old on CDK46 inhibitor, which she's tolerating quite well. It's been a year now since she's on the medicine. And from someone who came in a wheelchair, now completely walking on her own and doing her own work. So that's really the great thing about doing CDK46. Dr. Vinayak, any comorbids that you're worried about when you treat? I mean, is there some comorbid that will preclude use of any CDK46 inhibitor?
So QTC interval for ribocyclip.
Yeah, but then you can use the other
GI
drugs. Yeah.
So not all CDK inhibitors, but for GI symptoms, already GI existing symptoms, I would avoid abemaciclib. And Palbase, I've been using it. That's it.
Yeah, I think that's the fair enough thing, and for all of us, it's the same. I think wherever you will always find some CDK46 to fit some patient. I think that's the bottom line that I was going for. Next slide, please. Next slide. So again, we have discussed about the chemotherapy. Next slide. And coming to MBC in HER2 positive, is there still something that you would say are poor prognostic or something where you expect less? I've just given a list of liver lesion, PR negative, CNS. Are these really important, or is it something that we would probably not really decide on it? So, Dr. Saju?
Yes, sir. Actually, these all parameters are important. If the patient is presenting with bone-only disease, probably that is the best prognostic group. If the patient's having extensive liver mets, PR negativity, and with presence of CNS disease, they are going to perform bad with Cdk46 inhibitors. And in the scenario of primary endocrine resistance, also probably I would consider chemotherapy rather than this endocrine therapy.
Okay, that's an interesting thing. We'll come to the endocrine therapy. So, Dr. Saju, you can take the $1 million question. I think that is basically what we will be discussing in the next 5 minutes. How do you decide which CDK4 to use? We have 3. How do you decide which one to use?
As of now, I have used only palbociclib and ribocyclib. Abemaciclib I have not used.
Okay.
It was purely based upon the financial background of the patients, not based upon any comorbid status or anything.
Okay, but given a choice, you have a patient in front of you who can afford all 3. Because frankly, the cost of all 3 is by and large the same. I mean, with whatever support program, etc., it turns out to be almost the same price for all 3. Given that, how do you decide on your CDK46?
If the patient is having not having any cardiac problem or liver function is normal, then I would prefer ribocyclib first. Okay. And if he is having any comorbid issues, then palbociclib would be my first choice.
Okay. Dr. Rachna, you were talking about the preference of the CDK4 earlier. So how do you decide which CDK46 to go for?
So in the clinical practice, it is a financial thing which is guiding us to decide on the.
That's fine. You know, let's not get into finances. Everyone knows that's important. Yeah. But otherwise, patient in front of you with all options available.
Then I would like to look at if the patient is on multiple drugs for other comorbidities, if you're speaking about an elderly female, and then and if these drugs are going to increase the QTC interval, which ribocyclib is also going to affect, I would consider going for a palbociclib. Other than these minor things, there is no hard and fast rule that this is the CDK4/6 I would be using.
Okay. Dr. Vinayak, I have put this later in the course, but I'm just a bit curious. You know, we have now data from phase 3 trials, 3 phase 3 trials in the first line, one of which has not given us any overall survival benefit. One has given a definite OS benefit. One, it is pending with an interim study showing OS benefit. So if you don't have an OS benefit, would you still consider using palbociclib? Dr. Vinayak, you're on mute.
I would prefer to use palbase. The main reason for palbase usage is the tolerability for me.
Okay.
PFS benefit is good enough. In a metastatic disease, we can get only PFS as of now.
You have OS benefit in the other drug.
I know that part.
That's why I'm asking you. I'm just curious to know what people are thinking.
I have been now using more of ribocyclib than compared to palbase.
Okay.
We had a study for albaciclib when the trial was running with us. We had recruited almost close to 13 patients. The experience was not great in the trial setting itself.
Okay.
So, the answer.
Okay. No, fair enough. It's just a experience. Dr. Rekha, how do you decide on the CDK46?
So, sir, before the OS benefit data from Mona Lisa, I was thinking
Okay, I think we lost her right now.
Hello, am I audible, sir?
Now you're audible, yes.
Yeah, so I was saying I think the 3 CDK46 inhibitors are after all different, and OS benefit definitely changes my decision. I would prefer ribocyclib over palbociclib, and regarding the use of abemaciclib, maybe certain subsets, but then we do have data for ribocyclib even in CNS metastasis, even in PR negative. So I would say the 3 CDK46 inhibitors are after all different probably.
Okay, interesting. So Dr. Stalin, do you agree 3 CDK46 are somewhat different is what Dr. Rekha says? Do you agree with that, and how do you decide? Again, finances aside.
Yeah, definitely, sir. So keeping finances aside, if you give me an option, definitely with the current available phase 3 data, I will be choosing ribocyclib over other 2 because of the robust OS data it had compared to other 2 as of now, pending the final OS data of abemaciclib. So, but majority of my experience is with palbociclib.
Okay. Again, I think Palbo has been the first mover, so all of us are either comfortable with using Palbo, and that's one of the reasons why we seem to use it so much. So, Dr. Saju, do you agree with this? When you go into the trial depth, the EBIMA says that we have substratified the liver lesions, we have substratified the PR negative, and we have found benefit in that. There is a group which has shown CNS disease and is positive. Now, Ribo has come up with post hoc data and subset analysis again in the same subgroups. Dr. Satya showed us very nicely in the complement trial that CNS disease was included and everything seems to benefit. So do you think it matters that the trial included it upfront, or that you're getting post-op analysis and it's good enough? What do you think?
CNS disease, we have evidence for both Ribo and Abema.
Exactly, yeah.
Yeah, but I mean, otherwise, these substratifications are clinically not relevant as far as my personal view.
Okay. Okay. What do you think about this OS data with the Paloma, which really did not come? Now, numerically superior. Remember, it was numerically superior, just not the statistic significance. Now, in a different context, somebody just discussed with us and said, look, as long as I'm getting a PFS, I'm happy. It really does not matter the OS for me. Do you agree with that? Or do you think when you have one drug which is giving you OS anyway, why not use that? Why stick to one drug? What do you think about that?
Yeah, I mean, if the drug is giving a very good OS difference that statistically significant, then I would choose that drug. But practically speaking, it's like dasatinib, nilotinib, and bosutinib in CML. Whichever.
Okay, I think Dr. Stalin might have something to say to that. He had a very impassioned issue with dasatinib recently. But anyway, next slide, please. So again, I think the key takeaway from everybody in the panel does seem to be that, yes, there is some difference between the two. However, at some level, you may probably not read too much into the trial. As long as you're getting a good PFS advantage, you seem to be okay. And the tolerability and quality of life also seem to be more important for deciding which drug to give. So I think that's a very practical and normal aspect of how we actually treat in the clinics. Next slide. So these are the major trials that I have shown. Again, I'm not going into too much depth here. I think everyone is very well aware of the trials. Next slide. Next slide. This is the PFS advantage. Again, more or less similar for all the trials. And I'm not sure a couple of months extra in a cross trial comparison really matters. Next slide. Next slide. Next slide. So the last two questions is the one which I can you go back one slide, please? So last two questions are something which I was really wanting to discuss with everybody. Dr. Rachna, you can start. Do you think this different CDKs are interchangeable? Number one, somebody is on Ribo and they come to you, want to change it to Palbo, something like that. Would you ever do that? And secondly, monotherapy with CDK46. Again, not too much data on this. I'm just asking, do you think it is an option? Because the EBIMA people say that, yes, we have a monotherapy data. Is that at all any meaning for you?
So coming to the interchangeability, if the patient is recently started, I would say like 15 days or a month of one CDK4/6 inhibitor and not tolerating or developing a febrile neutropenia with palbociclib, yes, I would consider changing it. But if it is a longer course of therapy, I wouldn't plan to change the CDK4/6 inhibitor. And monotherapy, maybe in the third line setting, but not in the upfront or the second line setting. Based on that,
that's perfect. I think that's kind of what the data says. Dr. Vinayak, I'll ask you the most difficult, or rather the most controversial question. We might be getting some kind of a generic sooner or later. What then? Would you be happy to interchange when patient comes and asks you? Because costing is going to be different.
I have not changed till date any CDK inhibitor. That's because I have not used abemaciclib so much.
Okay.
But even generic is there. I think you must be knowing Palbis is available free of cost for BPL patients. So I don't see economical concerns will address that.
Okay, perfect. I think that's a very valid point. For those who really had problems, anyway, we're getting it free, so that will not really change what we are going to be doing. And that will continue to maintain whatever Ribo and EBIMA we were giving. I think that's a very valid point what you're making. Next slide. So regarding the hormonal partner, I think again, this is a question which has been done to death. I think by and large, everyone is comfortable with an AI. If it progresses on an AI, probably that's when we use a fulvestrant. Next slide. Next slide. So again, we have talked about the OS data and the importance of the real world evidence. Next slide. So just one or two more points we can discuss. Dr. Stalin, would you test Pic3 upfront or do you test it later?
So majority of the times we are testing it at progression, not
at
doing
progression
upfront.
only. Okay, and do you do liquid or do you do solid or do you do a sequential like what Dr. Charu was saying?
Sequential, sir. It is majority of the times it is sequential. First do a liquid. If it is negative, then a biopsy.
I think that's by and large what all of us are doing. I think these are all issues that have been kind of addressed over the past 2 years. There have been a series of pandemic induced webinars where we have been hammered with all these points, and I think by now all medical oncologists are aware of these things. Whether we do it in practice, sometimes we may not be doing it because of various reasons, and if a patient can't afford alpelisib, doing this test may not really make much difference, honestly speaking, but at least we are all aware of what to do. Next slide. Second line, when I'm talking about, I'm just talking of endocrine resistance. And again, very interesting comment Dr. Saju made, that if it's an endocrine resistant, he would probably still give some form of chemotherapy first rather than just going for a CDK46. Dr. Rekha, would you do? Would you still, primary endocrine resistance? There is data from Ribo as well as data from Abema. Would you go with that, or would you still prefer maybe some sort of chemo?
Primary endocrine resistance, I would try Abema, sir. So if
Okay.
the patient has not progressed on CDK4, definitely I would use CDK46 inhibitor, sir.
Okay, so I'm talking about endocrine resistance. So basically patient progressing in the first adjuvant, something like that. Okay, fair enough. Next slide. So just one more point that I would be talking about. Next slide. I think these all are things we have pretty much covered. Just the previous slide, please. So the last thing which I'll be talking about is this new trial that has come, the Maintain trial, on the benefit of continuing CDK46 inhibitor at progression. So Dr. Stalin, what do you think of that Maintain trial? It is a phase 2 study maintaining the ribocyclip while changing the hormonal treatment. Is this a valid option, or would you just prefer sticking to changing to the next line?
Possibly a valid option, sir. If the patient is a Pic3 non-mutant and not,
okay,
so then changing the endocrine therapy and continuing the CDK46 is a valid option. But this is just a phase 2 trial. But in the real world, definitely we can continue if the patient is affordable for it, especially if the patient is Pic3 non-mutant.
Perfect. Dr. Vinayak, your thoughts on this?
Yeah, I've been doing that. The thing is, Palbis is free after some time, and most of the ribocyclip is free after some cycles. At progression, I have changed the hormonal therapy instead of changing the whole line. And I have seen the responses after changing the hormone therapy. So I'm okay to maintain this data is phase 2, but our personal experience is being good.
I agree with you, and I think more importantly also is the degree of change. You have only a few extra mets, only few extra bone mets, non-symptomatic, no real visceral crisis or visceral disease. You are probably okay to just continue the CDK4 and maybe just change the hormone. That's the other thing we need to look into, the degree of progression. So I think with that, I'll probably close my talk, because we can discuss other things, but these are again topics that have been discussed and we are running a bit short of time. So if there's anything else which the panel wants to ask, there's one question which has come around. Dr. Stalin, if you can take this. So are all patients affording these targeted, or you try only in those who can afford, and how do you manage the patients who cannot afford CDK46? So it's a practical question that has been asked. So Dr. Stalin, if you can take that.
It's most relevant to my clinical practice also, sir. Majority of the patients who don't afford, but till now we managed with the patient support program of the PALBASE, and so many patients of de novo metastatic ER positive are receiving the CDK46 inhibitor. I don't think with the patient support program it is not that difficult thing.
Okay, fantastic. So thank you, everyone. I think that's a very nice panel. Again, I think these are topics where a lot of clarity is emerging on how we are going to treat. And most of our patients now, I think we are pretty clear on what we are going to be doing. Of course, as the data evolves, we are going to change our treatment and tailor our treatment and start looking at importance of sequencing. So,
sir, can I ask a question?
Absolutely, please.
Sir, any experience with the Tamoxifen along with the CDK46 inhibitors?
Okay, Dr. Rachna?
No, sir. I did not use it, sir. Use the combination.
Dr. Vinayak?
Used it in...
Yes,
Dr. Vinayak, just a minute.
Yeah.
So this question arises when you have premenopausal women. Just correct me if I'm wrong. So usually we go for ovarian suppression either by medical thing or by surgical and offer them postmenopausal status and AI. I have not used tamoxifen with CDK inhibitor till date.
Okay, Dr. Stalin, you were saying something.
Yeah, this comes to the point when seeing a male breast cancer also. I think that's a rare thing what we see in clinic, but in males, metastatic majority tend to be ER positive. They are metastatic, so this is a valid option. Tamoxifen plus Cdk46 inhibitor is a valid option because
But
tamoxifen is the most robustly studied ER targeted agent in male breast cancer.
Yeah, I think, but the ML7 included one of the Mona Lisa studies included males, and they used AI in that. But, yeah, Dr. Saju.
No, Vamshi, you have to go with along with orchiectomy because it is not complete if you give AI without suppression.
Yes, obviously. No, that's fine.
This is Dr. Meher. If
Yes,
you can permit me, I'll try to answer this question.
Yes, ma'am.
I did start a patient of premenopausal woman with tamoxifen plus AI. I planned to put her on palbociclib, but the support program did not allow to put the patient on tamoxifen. So they bought for a few months. Later on, I had to do the patient had to go for a oophorectomy, and later on I shifted to AI plus CDK4/6.
Okay.
So still, there are studies, and this combination can still be given in premenopausal women.
Oh, Dr. Saju, I hope that answers your question. So, anything else that you were looking for specifically in this?
Actually, in my clinical practice, I have used in few patients.
Okay.
I personally, I felt it works better than AI in premenopausal.
Okay. I have not used because, like Rashna says, everyone who is premenopausal will be made postmenopausal some way or the other. So I have not used it personally. I feel it. AI with a postmenopausal is probably a better option, but fair enough. This is something that we can explore. So again, if no other questions, thanks to all the panelists for a great discussion. And if you can just stop sharing the slide, thank you so much. So the last talk of today.
One more question in the chat box.
Okay, just a second. I saw only one question in that. There was one question which we have answered. There's only one question and one more in the chat box. Let me just open that. No, I am not seeing any question, Geetika.
Okay, sir.
Yeah, okay. So the last talk for today will be by Dr. Meher Lakshmi, and she'll be talking about the Pic3 inhibitor, picking the right strategy for patients with HR positive, HER2 negative breast cancer, the Pic3 mutations. So Dr. Meher Lakshmi is the Associate Professor of Medical Oncology at NIMS, Hyderabad. Madam, over to you.
Thank you, sir. Thanks for the opportunity. I thank the organizers for giving this opportunity. I will try to share my screen. I hope my screen is visible. Is my screen visible, sir?
Yes, madam.
Yes, ma'am.
Okay, thank you. So this is the last talk. I'll quickly rush through the data and the role of alpelisib in the Pic3 Cm mutated breast cancer patients. So this is the data. 40% of patients with HR positive advanced breast cancer have a Pic3ca mutation. But Madam has previously said that we have Indian data where 28% of our patients have shown mutation of Pic3ca. And all these were discussed why they need a different approach. We all know these patients have a poorer prognosis. There are two major studies, a genomic analysis of 649 metastatic breast cancer patients and a meta-analysis of 1929 cases of patients, which all show that this presence of Pic3ca mutation, they have a negative prognostic, which is a negative prognostic factor in the survival of breast cancer patients. And it is better we know the mutation upfront because we can prognosticate the patient and also we can tailor the therapy. And coming to alpelisib specifically targets the alpha isoform of Pic3 kinase. We have alpha, beta, gamma, and delta. Unlike the other agents like which we have before, which were which inhibited all the isoforms and because of which they had much more side effects. This Pluvicto, that is alpelisib, specifically targets the alpha isoform, and hence there's a different side effect profile compared to the former agents. And all these were discussed before, but I'll quickly rush to when to test archival tissues or the repeat biopsy, which was already answered, the what test and the concordance rate. And when to test, usually When a patient with advanced breast cancer comes, when we do a biopsy, at the same time, Pic3 mutation can also be done. And these Pic3 mutations are generally stable. And but a patient, if the progresses, we tend to do a liquid biopsy, and if it's negative, we tend to do a tissue biopsy. But of late, what we are doing is, if we see a patient with advanced breast cancer patients, when we do a biopsy and send for ERP or HER, at the same time, Pic3 mutation can also be tested. And which hotspots to look for? It was already discussed that the most common mutations are seen in exon 9 and exon 20. And how to test is by either RT-PCR or NGS. RT-PCR, the results are quick and the test can be repeated, but as NGS, it gives a idea of almost all the entire gene panel, but it's expensive. With sample, again, the tissue, it's always the best. In case the patient has progressed and we have not tested before, we tend to do a liquid biopsy. And if it's negative, again, we need to do a tissue biopsy. And now the Pluvicto, that is alpelisib, is a critical component in the treatment plan of advanced breast cancer patients. And even NCCN guidelines, so this shows that alpelisib plus fulvestrant therapy is the preferred option in those patients who harbor a Pic3ca mutation. And this is the SOLAR trial. The SOLAR is the first phase 1 trial which led to the approval specifically for advanced breast cancer patients with Pic3ca mutation. This included patients with the postmenopausal women and also men who are hormone receptor positive, HER2 negative advanced breast cancer, and also those patients who had regressed or progression during or after an AI therapy. These patients are randomized to Pluvicto 300 mg daily versus placebo. The primary endpoint is progression-free survival. If we see the data, 11 months PFS in those patients who used alpelisib, Pluvicto, 11 months versus 5.7 months. We can see there's clearly the divergence of curves. There's almost more than double the PFS with the use of Pluvicto. And coming to PFS across all the subgroups, there is consistent benefit across all the subgroups. And how coming to response rates? When not only the progression-free survival, even the response rates are more than double with the use of Pluvicto plus fulvestrant. And coming to responses, see this waterfall. If you see the waterfall plot, around 76 patients, they experienced a reduction in tumor burden, and they also experienced deeper responses with Pluvicto. And coming to dosing administration, it's the standard dose is 300 mg once daily, and if the patient experiences side effects, the first dose reduction is to 250 mg, the next dose reduction is to 200 mg. And Pluvicto is now approved in combination with fulvestrant. And coming to adverse effects, the main adverse effects are the hyperglycemia, rash, and also diarrhea. This hyperglycemia is seen around 37% of the patients. Rash around 19.7%. Diarrhea is around 6.7, around 7%. So the most important complications are mainly hyperglycemia and rash. Diarrhea also in 7%, but not so, which is manageable. If you see hyperglycemia, if you see around 40%, 37% as per the data, if you see is a very important complication. If you see the slide, the Pic3ca inhibition, it blocks the glucose uptake. Hence, because of the blockage of Pic3 kinase, there is a blockage of glucose uptake, and hence patients have hyperglycemia. So the dose modifications need to be done based on the glucose levels. Metformin is actually the drug which was used in the SOLAR trial, but if the patient the sugars are uncontrolled, insulin does help. In fact, we had a patient who was on alpelisib with renal failure, for whom we could not use metformin, and the sugars were controlled with the use of insulin. So metformin is actually the drug of choice, but in certain circumstances, insulin too can be used. And so sugar monitoring needs to be done, fasting blood sugar and also HbA1c. Initially, we need to monitor more aggressively, and once the patient tolerates and if there is no episode of hyperglycemia, the frequency can be lessened. Again, coming to the management of rash, when we use a prophylactic antihistamines and moisturizers, the incidence of rash is much lesser. Even if in the trial, if we see those who use prophylactic treatment prior to the onset of rash, 73% did not experience any rash. But if they're not receiving treatment, only 36% they were spared, so rest all had rash. So it is very important you use prophylactic antihistaminics and also moisturizers prior to you onset of rash. This can reduce the onset of rash and patients will feel more. What are the quality of life? And there was the alpalicip assessed quality of life impact on URTs, and if you see the brief pain inventory scales, and if you see they maintained the quality of life and function status were maintained on alpalicip treatment. There is no difference in the overall adjusted mean changes from the baseline in the functioning scores. And even after time, if you see the time to the treatment discontinuation analysis, they also showed that it's no demonstrated difference between the two treatment arms over 28 months, whether they used alpalicip or the placebo. Even the physical and emotional functional assessment, they all favored alpalicip. It also showed a positive impact on the symptom management. So summarizing, Pic3 Cm mutations are present in 40%, 28% in Indian setting, and they indicate a poorer prognosis. So now we have alpalicip, which specifically targets Pic3 Cm mutations. There is nearly doubling of median PFS in patients with Pic3 Cm mutation with the use of alpalicip, more than double the response rates. And safety-wise, patients, they are well tolerated. Pic3 Cm mutation, there is no difference in the functional outcome with the use of alpalicip. I thank the organizers for giving this opportunity. Thank you all.
Thank you, ma'am. That was, as usual, a crisp and cogent talk on alpalicip. So I think we have had quite a long talk on a weekday, but very interesting sessions. And I thank all the panelists and all the speakers for a fantastic discussion on breast cancer, especially the HR positive breast cancer. Truly a paradigm changing malignancy, which in the last few years, again, a lot of us like me have been fortunate that we have seen this change in the last 6-7 years and have grown up with the changes of the HR positive drug. So thank you once again to everybody, and thanks to Novartis and